I'd like to now invite Associate Professor Pedro Povoa to speak to us on the topic of how biomarkers may be able to solve some of these problems which Jan so very eloquently characterised for us. Pedro works at the University of Lisbon in Portugal and is someone who I often see being the first person to be asked on this topic at each of the European Society of Intensive Care Medicine meetings that I've been fortunate enough to attend over the years. And so I'm very interested in hearing his views on how biomarkers can help improve sepsis diagnosis. Thank you, Pedro.
Thank you, Jason, for this very kind introduction and also for the invitation to be speaking in this very interesting webinar. And I also want to say to the attendees, good afternoon or good morning or good night, depends where they are. As Diane just said, what is difficult is not the diagnosis of sepsis and organ dysfunction. What is difficult is diagnosing infection. And in the next 15 minutes, I will try to show you how we can use safely biomarkers to improve our diagnosis. Sorry. These are my disclosures for this topic. And I will address first, what are the most studied biomarkers? And then how can biomarkers be helpful in clinical practice? And how can biomarkers improve our diagnosis? And concerning the number of biomarkers of sepsis, this paper published by Pierre Racos and Jean-Louis Vincent last year, that is an update of a previous paper published 10 years before. Till September 2019, they found 258 biomarkers of sepsis. And if you look at the number of references published in the last decades, you see that there's an exponential rise in papers on biomarkers of sepsis. And the number of new biomarkers appearing is decreasing a little. But why such a rush for new biomarkers? If you compare to, let's say, acute myocardial infarction, we have troponin, creatine kinase, pro-BNP, and these are enough for this also quite frequent disease. And the problem is that we didn't find yet the ideal biomarker, and also at the same time, as Jan just said, the diagnosis of infection is also difficult. It's not a yes or no. There's sometimes a gray zone where we don't know if the patient is infected or not. So there is no gold standard for the diagnosis of infection. Looking at the biomarkers that have more research done and more published papers, it is procalcitonin and C-reactive protein. But before using them, it is important to know, and this is true not only for these two, but for every biomarker, we should know lots of things about the biomarkers because there are no perfect biomarkers. We should know where the biomarker comes from. We should know a little bit of the biology of the biomarker. When it starts to increase, the doubling time, the peak concentration, the half-life, what are the possible confounders of the biomarker? And one of the things, for instance, renal failure increases, the level of procalcitonin, renal replacement decreases. Chronic liver disease, it decreases slightly the level of C-reactive protein, but in acute liver failure, there's no C-reactive protein, no increase. There are some situations that have marked impact on the levels of biomarkers, both PCT and C-reactive protein. Another important issue that I'm going to show later is if we have sequential, more than one infection, what happens to the peak of the second episode, and in the PCT it seems to be only 10% of the first episode. In CRP is 70% of the first episode, and both are not that good for the differentiation between bacterial and viral infections. So let's look now at how can biomarkers be helpful in clinical practice, and how can them improve our diagnostic ability. And again, when we are facing patients, we ask all the time questions. We ask questions if the patient is infected, and the infection is treated with antibiotics plus minus source control. And sepsis itself, that is our response to the infection, is important to have early recognition, and again, supportive care is more related to the organ dysfunction. And concerning the infection, we ask questions every day. We ask questions like, what is the risk of poor outcome? What is this patient at risk of an infection? Is this patient infected? Is the infection refractory to antibiotic therapy that I prescribe? Is there an infection complication? Is the infection cured? And all of these questions are related to different times and different actions that we do when assessing a patient with a possible infection or already under treatment. And I'm going to review only the issue of diagnosis of infection. And how can biomarkers help us in the diagnosis of infection? And we can use biomarkers in two ways. Just looking at one determination of a biomarker, or looking at serial determinations at the kinetics of the biomarker. And here, just looking at if the kinetics and the course of the biomarker can help us in predicting infection. Let's start with a single determination. This is a paper that we published more than 10 years ago. It was a systematic review where we look at the ability of a single value of CRP and PCT to diagnose a documented, microbiological documented infection versus no infection and no antibiotics, and either CRP and PCT as a reasonably good area under the curve and the ability to diagnose infection. And what I would like to point you is to these studies, one from our group and another from a Spanish group, that just for chance that we performed almost a similar study without knowing each other, with similar criteria of inclusion and exclusion, and we end up with almost the same results. More recently, we assessed the ability of CRP, PCT, and pro-adrenomedeline in the diagnosis of EAP, again, a single value, and with quite good ability to identify ventilator-associated pneumonia. A larger study of 279 patients, comparing those with sepsis and non-septic SIRS. They look at more than 50 biomarkers, some of them old blood RNAs and leukocyte surface markers. And what they found in terms of their diagnostic ability for sepsis is that the performance was not that good, with the exception of CRP that was quite different. And all these circulating biomarkers tested in this study were found to discriminate poorly between sepsis and non-septic SIRS, and there was no combination of biomarkers that performed better than CRP alone, with an area under the curve around 25. This is an example of a study using panels of biomarkers. What they did was they assessed almost 1,000 patients at the emergency department. They begin to make an exploratory study assessing more than 150 biomarkers in 250 patients, where they select 9. And then of these 9, those that performed better was the combination of IL-1 receptor antagonist for inflammation that reflects inflammation, protein C that reflects coagulation, and NGAL that reflects injury. And the combination of these 3 biomarkers has an area under the curve of 0.80. The issue of primary and secondary sepsis episode is also quite important. This is what happened for the peak of procalcitonin between the first septic episodes and the patient with a second septic episode, and the value of the peak is around 10% of the first one. And concerning CRP, the second is more or less 70% of the first one. Be aware that this is a logarithmic scale and this is a linear scale. If this is a logarithmic scale, it looks quite linear scale, it would look quite differently. Another way is to look at the biomarkers not in the blood but in other organ fluids like BAL. And in this study, they look at IL-1 beta and IL-8 in the bronchoalveolar lavage fluid, and those patients with low levels of both biomarkers, they have a quite reduced risk of VAP. And then these authors performed a validation study with more patients, 150, and with a combination of these two biomarkers, they have a sensitivity of 100% to exclude VAP and a post-test probability of 0. So it is very sensitive to exclude VAP, the combination of these two low levels of these two biomarkers. What we did a couple of years ago is to look at the volatile organic compounds in the exhaled air. This is a non-invasive technique that could give you quite interesting data. The volatile organic compounds could come from the host, but could come also from the bacteria that we have in our respiratory tract. And according to the type of volatile organic compounds, we could ideally, and we have some data showing this, to show patients that have a VAP versus patients that do not have VAP and are only colonized. And also you're trying to see if there is a sort of a VOC fingerprint of different pathogens that we could also direct more specifically what antibiotic to prescribe, and then to see in a sequential time frame what is the course of the VOC pattern, and to see if the patient is improving and not improving, and also to stop antibiotic therapy in a non-invasive way. Jan has already touched this. This is just an example of genomics comparing patients with VAP and VAT, tracheobronchitis, with different activation of genes, and patients with VAP have a relative depression of genes involved in complement systems, cyclic AMP and calcium signaling pathways, and this could explain why patients with VAP exhibit more inflammation and worse outcomes comparing to VAT. Now I'm going to address the issue of the kinetics of the changes of biomarkers before diagnosis and how they can help us in prediction. This is the first paper that came from our study, where we studied the kinetics of CRP before the diagnosis of ICU-acquired infection, comparing to patients that were not receiving antibiotics, were not, they have no diagnosis of infection, and were discharged alive. And as you can see, those patients, there were no change in CRP, and patients that develop an ICU-acquired infection, they have a marked increase. And looking not at the absolute value, but at the changes, the daily changes of C-reactive protein, the area under the curve was quite good. And if we combine the maximal daily CRP change, this is the best cutoff, plus the absolute value that came from our study on a single determination at the day of diagnosis of infection, this is a quite good way of identifying patients with high risk of infection with a good sensitivity and specificity. The positive likelihood ratio is not that good, but the negative likelihood ratio is very interesting. The group from Jean-Charles reproduced the same methodology in PCT in patients under mechanical ventilation with and without VAP. And what they found is that PCT, both crude values and kinetics, were poor in the diagnostic of VAP with poor area under the curves, as you can see. We then made a study also on patients under mechanical ventilation that start the ventilation without an infection cause. So these patients were not receiving antibiotics. And we assessed the course of CRP and PCT until the diagnosis of the VAP or not having an infection. And concerning CRP, those that do not develop infection, CRP remains more or less the same. And those that develop a VAP, it is increasing. And so the time-dependent analysis was significantly different between these two patient populations. And after day 5, day 6, the difference was significant. Looking at procalcitonin, there was no difference in the time-dependent analysis, was not significantly different between patients that are going to develop VAP or the controls. And then we look at the slope of the linear regression of the values of CRP and also PCT during the first week of mechanical ventilation. And the slope of CRP was significantly associated with the risk of developing a VAP. And in this calibration plot, it's clear that the higher the slope, the higher the risk of developing VAP. But concerning the slopes of procalcitonin, we were not able to find any relationship between the slope and the risk of VAP. And so from our data, a patient with an average increase in CRP of 1 milligram per day, of deciliter per day during the first week has a 60% greater chance of having a VAP compared to a patient with no CRP increase. From the same study, we also look to different biomarkers, coagulation, pro-inflammatory, anti-inflammatory, acute phase response, and apoptosis in day 0 and day -3. And the biomarker that has the best performance was TNF receptor 1. That is also showing that could be a promising marker not only for the diagnosis, but prediction of VAP 3 days before. And finally, I'm going to show some data from a population-based database from Denmark, where I also work. And what we studied was the kinetics of the biomarkers before the diagnosis of bloodstream infection. Day 0 was the day of the diagnosis of bloodstream infection. And we look back till day -30 of CRP and albumin in these patient-based database. And we modeled these dots as a broken stick where there are 2 linear regressions that were defined in 2 distant time intervals between day -30 to a certain time point in this time interval, in between the day of diagnosis of bloodstream infection and the same time interval, trying to find the place where there is a greater change in the kinetics of the concentration of the biomarker. And what we found is that CRP begins to increase 3 days before the diagnosis of bloodstream infection, and albumin 1 day before, 1.5 days before. And as you can see, the slope of the CRP was almost flat in the days before and then increases markedly after day -3. And concerning albumin is almost flat in the days before and begin to decrease in around 1.5 days before the diagnosis. So in conclusion, biomarkers are useful in the diagnosis of sepsis and infection, but we need to know the biology, the strengths and limitations of the biomarker that we are using. We have to use biomarkers cautiously in those that give additional information at the bedside. But the biomarkers are not a panacea. They should never be used solely. We should not treat the number. We should not prescribe or not prescribe antibiotics just because of the number of the biomarker. We should always use them in conjunction with a complete clinical evaluation. We should look at the patient. And again, biological systems are very complex, and we should be wary of very good results. Thank you very much, and I'm happy to take questions.
Thanks, Pedro. There's a lot of information that you covered expertly. I'm really grateful for that.